Hello, I'm Conrad Fisher, and welcome to your USMLE Step 2 preparatory course. We're going to take every disease and we're going to divide it up into what is the most likely diagnosis, what is the best initial test, what is the most accurate test, what is the best initial therapy, what is the adverse effect of the best initial therapy, what is the physical finding most likely to be found with this disease. Now, when you go into test day, you can't relax by somebody telling you, hey, yo, relax. No one ever got relaxed by someone saying, hey, relax. You get relaxed by being prepared for all of the questions so that when you go in, you're confident. Hey, I'm almost certainly going to get a stroke question. I want to be able to answer all of those questions. So give me all of the variants that you can see, and that way when you get to test day, you'll be able to say, I know the answer to the question. What is the best initial test? What is the most accurate test? What is the best initial therapy? What is the adverse effect? Which physical finding? Almost all strokes are embolic or ischemic. They either form in place, not so much, or they come as embolic from the heart. Bleeding is much less. Now, there's not much you can do about bleeding into the brain because the very process of going in to try and repair a bleed, an active bleeder in the middle of the brain, only makes it worse. You would have to dig down. It would make it terrible as you go digging in. Now, emboli originate from the carotid, sometimes from the heart, sometimes. They can come from valvular disease. Which valvular disease? The most? The metal valve, of course. That's why the strongest indication for the use of warfarin is mitral stenosis or metallic valves. What's the only time when we do use warfarin that you go above the INR of 2 to 3? Metal valves. Atrial fibrillation, CHADS 2 or above, CHADS 2 or above, and we're going to use anticoagulation with something like a NOAC or DVT through the patent foraminal valley. Now, 1/3 of the population has a patent foraminal valley, but they don't necessarily have right to left shunting. How would you determine if there was right to left shunting? A bubble study. That's why everybody with anterior or middle cerebral artery strokes, everyone with an anterior or middle cerebral artery strokes needs evaluation of their carotids, because at what percentage will you do endarterectomy? 70%. What do you do for asymptomatic carotid stenosis? Nothing. Mostly nothing. Mostly nothing. Middle cerebral artery is most strokes simply for one very straightforward reason, because it's the largest artery. It's the largest amount of flow. So it's logical that that's where most of the strokes go. Where the largest amount of flow, that's where the strokes go. You don't need me to say that if you have a stroke on the left, you're weak on the right side of your body. You don't need me to say if you have a stroke on the left, you can't see the right side of the world. You don't need me to be able to say that if you have a stroke on the left, 90% of the time you lose speech, because speech and handedness follow each other. 90% of people are right-handed, and 90% of people have their speech center on the left side of their brain. They go together. Homonymous hemianopsia. The same way if I have a stroke on the left, I can't feel and I can't move the right side of my body. The same way, if you have a stroke on the left, you can't see the right side of the world. So what happens is your eyes deviate to the other side. If you can't see the right side of the world, your eyes deviate to the left. Your eyes look at the lesion. They look towards the side of the lesion. Aphasia, now speech and handedness don't always follow each other, but they do most of the time. And anterior cerebral artery. You're going to only get asked one special question because the best initial therapy is the same. Thrombolytics in 3 hours, sometimes up to 4.5 hours. Catheter removal up to 6, 8, 12 hours. Echocardiogram to look for clots and to look for valve disease. Carotid disease to be able to look to see whether or not you need endarterectomy. EKG telemetry, loop recorder. Loop recorder is a long-term EKG monitor that's implanted, long-term EKG monitor, because 20% of the people at 6 months turn out to have AFib, even if the initial Holter was negative. I just gave you the whole of stroke management in 30 seconds. So then tell me, fishy, then what's different about anterior cerebral? What's different so that we need to know that you can answer the question? What unique question? Because AFib causing stroke is not unique with anterior cerebral. The heart causing stroke with embolic phenomenon is not unique. Carotid disease causing stroke is not unique. Thrombolytics to 3 or 4.5 hours is not unique. Catheter retrieval is not unique. Aspirin later on, or adding dipridamol, switching to clopidogrel, that's not unique. What's unique is a unique answer to the question, what is the most likely diagnosis? And what is the most likely diagnosis? You have personality or cognitive dysfunction because you are here. Your personality lives in your anterior cerebral arteries. Your personality lives in your anterior cerebral artery because that's where your frontal lobes are, your personality. And leg weakness, leg weakness, leg weakness, leg. I want to kick you, I can't kick you, so I pee on you. Personality, urinary incontinence, leg weakness. Now, what's different about posterior cerebral? Now, posterior cerebral artery circulation could be called posterior, it can be called cerebellar, it can be called brainstem, it can be called vertebral basilar. vertebral artery, basal artery, vertebral arteries, and basal arteries. And what's different? It's the only place where you can lose consciousness with a stroke. You can't lose consciousness with the stroke of the anterior or middle cerebral arteries. So every time you see somebody admitted for syncope and they're doing a CT scan of the head looking for a cause of syncope, you can walk up to them and go, I know more than you know. You're doing that CT to look for a cause of syncope, but you cannot syncopise from anterior and middle cerebral. You need to do a brain stem. You need to do MRI. You don't know. Yeah, you're ignorant. Can I have my little recommendation now? Posterior cerebral artery stroke is the only one that causes dizziness or loss of consciousness. Posterior cerebral circulation or vertebrobasal is the only one that gives bilateral findings. It's also that gives all the brainstem findings. So where's the nuclei of the brainstem? Where are the nuclei? Where are the nuclei? They're in the brainstem. Where are the nuclei of the cranial nerves? They're in the brainstem. So therefore, it gives you diplopia because cranial nerves 3, 4, 6, 3, 4, 6, diplopia, double vision. It gives you dysarthria. Now that's different than aphasia. Aphasia is inside the brain. You can't perceive and understand or even express words, but dysarthria is an inability to phonate. No ifs, ands, or buts about it. I can't phonate. So it's the only way that you can get bilateral findings. It's the only way you get cranial nerve findings, because where are the cranial nerve nuclei? In the brainstem. Diplopia, cranial nerves 3, 4, and 6. Dysarthria, okay, cranial nerves, lots. Oh, dysphagia, cranial nerves 9 and 10. And that's where all these small syndromes, the Benedict syndrome and various different small pica, ICA. And for you, from the point of view of step 2, it is not really worth you learning the difference between multiple small posterior cerebral artery circulation strokes. You just have to know brainstem nuclei, dizzy, dysarthria, dysphonia, dysphagia, D. And because it affects cerebellar circulation leads to ataxia, because that's what cerebellars do. They control your ability to maintain balance. So the best initial test is CT without contrast. Contrast is looking for cancers and infections. So the most accurate test is an MRI. Well, that's true for everything. That's true for everything, isn't it? Best initial test, CT. Most accurate test, MRI. Except multiple sclerosis. In multiple sclerosis, there's no point in getting a CT. Goes straight to MRI with multiple sclerosis. The CT scan is essentially being done first to look for blood. It's going to look for blood because if you've just had a stroke, the CT will show blood immediately, but it won't show ischemic strokes. We won't get 95% sensitivity up to 3 to 4 days, 4 and 5 days, a long time. If you were to put a piece of meat out now, it'll look exactly the same tomorrow. The MRI, in order to find blood, will show blood immediately, but an ischemic stroke will show in 24 hours. Now, the other thing about the MRI is if you add contrast, what's that contrast for the MRI? Gadolinium, contraindicated when you have renal failure, contraindicated in renal failure because it causes nephrogenic systemic fibrosis. So the MRI, if you add contrast, if you do flow scans, if you do various forms of enhanced MRI, they can essentially show the stroke instantly. So what do we see here? We see a non-hemorrhagic stroke on this side of the middle cerebral artery, and we see a hemorrhagic stroke over here because blood comes out white. Now this is why when we're looking for blood, we don't need contrast, because contrast itself looks white. We do contrast when we're looking for cancers and infection. This is a middle cerebral artery stroke. So the next step in the management of this patient is to look at the heart for embolic source, to look at the carotids for embolic source, to do an EKG, telemetry, Holter monitor, long-term loop recorder if they're negative, to look for AFib, middle cerebral artery strokes. So the best initial therapy, if there's hemorrhage, unfortunately we have nothing to do. Now the treatment for non-hemorrhagic strokes is based entirely on the time frame with which people come in. So hemorrhagic is tragic, but there's no knowledge base. Non-hemorrhagic, the standard of care is to use thrombolytics in anyone in whom there's not an absolute contraindication if they come in 3 hours. Now you can go out to 4.5 hours if you have people that are at less risk of bleeding, because no one wants to turn their brain hemorrhagic. So you do it if the person is not terribly old, because we know as people age, the blood vessels in their brain become more fragile, and therefore the risk of dying of a bleeding becomes more than the benefit of the thrombolytics. We know also that really severe strokes tend to bleed more. So you have to have an NIH stroke scale that's more mild, because really severe strokes fracture and you bleed into your brain. We also don't want to give it to diabetics with previous strokes, because again, the blood vessels are fragile, or people on active anticoagulation like a NOAC. So you can go up to 4.5 hours as long as the risk of bleeding is low. Now, after 24 hours, after thrombolytics, you're going to start an antiplatelet drug. 24 hours after the thrombolytics, you start aspirin. But what if the question says the patient is using aspirin routinely? The patient is using aspirin routinely, then you add dipridamole or switch to clopidogrel. Now you notice I have to say clopidogrel, I can't say Plavix, because step 2 and Comlex 2 only test generic names. They don't test manufacturers' names. So that is why you'll have to memorize. Then you have to go through life saying metronidazole instead of Flagyl. I know. You'll also notice no dosing, because dosing is not tested on USMLE. But the route of administration is important. You're tested on route, but not dosing and not manufacturer's names. Now you'll also notice that we will never say to you for stroke, consult anybody. You're not supposed to need a consultant to tell you to get a contrast negative CT for initial management of a stroke. And you're not supposed to need a consultant to tell you posterior vertebral circulation cerebellar strokes present with bilateral findings. They can cause loss of consciousness. They'll cause all the cranial nerve difficulties. Now, for internal medicine boards, you would have to know some of the specific stroke syndromes posteriorly, but not now. Now, if you're more than 4.5 hours after the onset of stroke, it's too late for thrombolytics, what can we do? Well, you can do an aspirin, certainly. But aspirin only prevents the next stroke. So what can you do if you're more than 4.5 hours? There's no treatment for hemorrhagic stroke. The surgical drainage is only going to make it worse. So why not combine? Wait a second, fishy. I've seen plenty of patients on dual antiplatelet therapy. What do you mean don't combine them? Okay? Every day I go to the hospital, I'm in the cardiac unit, I'm in the general medical floors. I see people who got stented, people morning, noon, and night stented. They're using aspirin and clopidogrel, aspirin ticagrelor, aspirin and prasugrel. The answer is that there are a lot of things that you can use in the heart that don't cause bleeding. Have you ever heard of cardiac hemorrhage? Well, there's cardiac rupture, there's wall rupture, there's septal rupture. But bleeding into the heart, cardiac hematoma? No. There's not, you don't get a cardiac hematoma for 2 reasons. Number one, coronaries are much tougher, much thicker, much more like your quadriceps compared to the blood vessels in your brain. Or to speak poetically, our hearts can stand almost everything, but our thoughts are so vulnerable. The second thing is this. The heart is muscular contractile tissue, so if you bled into the muscle, how can you bleed in the muscle when it's contracting? But bleeding into the brain? Easy, because the brain is relatively soft and mushy. So in the heart, adding clopidogrel adds efficacy, particularly if you've been stented. In the brain, adding clopidogrel adds death, because it makes you bleed. If you're too late for thrombolytics, it's time to, and I love it, get in there and snatch that thing out with a catheter. Now, catheter retrieval is not angioplasty, because angioplasty is good in the heart, but in the brain it would rupture it. So you're not going to get pimped on stuff like, is it 6 hours, 8 hours, 12 hours, because it's not so clear, and that's not a student level of question. That's not a step 2 question. It also is a moving target. The moral of the story is you can go much later to pull it out. Angioplasty, no. So you see there's a real opportunity here to make mistakes in stroke management, because there's a lot of overlap with cardiac disease. Platelet drugs, thrombolytics, but IV heparin. IV heparin is used never in a stroke. It makes you bleed. And almost never in the heart too, because in the heart, when we have non-ST elevation MIs, what you would call NSTEMIs, we can use low molecular weight heparin. In the heart, low molecular weight heparin, good. Yes, my friends, low molecular weight heparin in the heart is good, but in the brain, it makes you bleed. Prasugrel with the stent, Ooh, Satyam Shivam Sundaram. Truth is eternal and beautiful. Yes, Bahodacha in the heart. But in the brain, having a previous stroke or current stroke is a contraindication to the use of prasugrel, because prasugrel will make you bleed. Statins are used in everybody in the heart, no matter what the LDL is. Statins are used in everybody in the heart, no matter what the LDL is. But in the brain, statins are used only all the time. Oh yeah, it's the same, ain't it? So ends up being what's the same? The use of aspirin and the use of statins for both hearts and brains. So statins in everybody, regardless of LDL, but the target should be under 70. Regardless of LDL, but the target should be, seems contradictory. It does. For non-hemorrhagic strokes, remember, statins won't do anything for a hemorrhagic stroke. Every stroke means a statin. And statins also to what LDL? Now this is contradictory, so let's say this again. Lipid guidelines are one of the things that's changing, and you should expect them. They're going to change every year. People get together. Multi-billion-dollar drugs, very unclear. Should you be going to goals? Should you not? Well, what we know is this. Any atherosclerotic disease, and atherosclerotic disease means cerebral vascular disease, statin in everybody. Carotid disease, statin in everybody. Coronary disease, statin in everybody. Aortic disease, not the valve, but the blood vessel, statin in everybody. Peripheral disease, statin in everybody. Who else gets a statin? Diabetics with an LDL above 100, and people have a greater than 7.5% 10-year risk of MI. 7.5% 10-year risk of MI. Any LDL, but the goal should be understood. Contradictory, I know. So why do an echo? Because you're looking for the source. You might replace a certain valve, and you might go in and give anticoagulation. If you saw a clot, if you see a clot, you'll anticoagulate. Patent foramen ovale. Now, patent foramen ovale, so there we said, how many? What percentage? What percentage? It is in 30%. Now, let me remind you at this time that although these videos with the book, you combine the videos with the book, and at the end you use our questions to assess yourself. So if I was you, this is what I'd do. I'd read the book. I'd watch some videos, I'd read the book. Read, watch, read, and use the questions to assess your knowledge base at the end. So if you went through here and this thing about, using this about, well, when do we close a patent foramen ovale? That's relatively new in the grand scheme of the history of stroke. You close it if it's a cryptogenic. There's a $5 word, cryptogenic. Crypto, tails from the crypto, unknown. Unknown. That's what it is. Cryptococcus. I got a fungus that I don't know where it comes from. Cryptosporidium. I got diarrhea. I don't know where it comes from. Cryptogenic means that the echo is negative, the telemetry monitor is negative, and the Holter. What's the difference between tele and Holter? One's inpatient and one's ambulatory most of the time. So you don't find anything in the heart. You don't find anything on any arrhythmia, and you don't find anything in the carotids. That's cryptogenic stroke. And if you're under the age of 60 with a cryptogenic stroke and right to left shunty, Om, shanti, om, shunt my mom. Under the age of 60, cryptogenic, meaning everything is negative, then you would consider PFO closure. So you're doing this because it's automatically a CHADS of 2. Does a TIA, transient ischemic attack, no residual deficits, does that count as a CHADS of 2? If you're cryptogenic, if you have a CHADS of 2, does it count as a CHADS of 2 if you've just had a TIA? Yes, it does. Stroke or TIA. So when you're doing these things in these evaluations, you're going to look for anybody who's got a CHADS of 2 to tell you whether or not somebody needs, if you have AFib. And that's a very important issue because it means even if you have a patent foramen ovale, even if it means you have a patent foramen ovale, if you have AFib, you're not going to close the foramen. Because if you have AFib, it's not cryptogenic. Cryptogenic means the Holter, the EKG, the carotids are all clean. If it's 100% stenosis of the carotids, then it's no intervention, because if you've managed to live without the carotids and you have 100%, you don't need to do endarterectomy now. Now, here's the thing. In the heart, angioplasty, PCI angioplasty is excellent. But in the carotids, angioplasty is not excellent. In the heart, we stent. In the brain, we don't stent. And just like in the heart, to be considered significant stenosis, it has to be about 50 to 70%. Over 70% is a definite. So in the heart and in the carotids, 70% is definitely serious. 50 to 70 is probably not serious. Under 50 is definitely not serious at all. So if it's under 50%, the answer is no intervention. 100% no intervention because you've learned to live without it. I don't worry about hair loss. If it's 100% occlusion, it's already too late, nothing to do. To stroke, you're using the Telly and the Holter to detect fib and flutter. Well, what's the difference between the management of flutter compared to atrial fibrillation? And the answer is essentially nothing. But most people don't stay in atrial flutter. They either go back into sinus or they go on to atrial fibrillation. But the management and the treatment is the same for both of them, even if there's a TIA, because it's automatically a CHADS of 2. Carotid stenosis equivalent, that's why everybody is going to get a statin for everybody's care. And also for carotid stenosis, is there a particular blood pressure medication? Is there a particular blood pressure medication for carotid stenosis that's better? No. For peripheral disease, yes. For peripheral disease, it's an ACE inhibitor. Angioplasty and stenting is for the heart, not for strokes. Now, I'm going to do the PFO closure again because this is difficult for a lot of people. People get this mistaken a lot. So, patent foraminal valley, we're not closing if you have a patent foraminal valley. That's 1 out of every 3 people. You're closing if you have a stroke. You're closing if you can show shunting, that there's right to left shunting by an echocardiographic bubble study. No, I have evidence of shunting, so I can have an embolus out of my right side. And there's no point in closing them for 70 and 80-year-olds because you go, by the way, how do you close it? It's not surgery. You close it with a catheter. Put a clamshell in there. Cryptogenic, and this word knows where you're really going to be ahead of everybody else. Cryptogenic means negative carotids. It's not coming from your carotids. It's not coming from your heart. But the big one is, if you've got AFib, it's not cryptogenic. Don't close the PFO. NOAC the AFib. How far do I have to go to be sure there's no AFib? And it's not just enough to do an EKG, telemetry monitoring, or a 24-hour Holter. You have to do at least a 30-day study to be able to be sure there's no AFib, because a lot of people have AFib not picked up in the original EKG and telemetry. Now, even if you close it, you still have to keep using aspirin, even if you close it with a catheter. Cryptogenic means no arrhythmia. Cryptogenic means no carotid disease. Cryptogenic means no valvular disease. Cryptogenic means that you're going to find the origin. How do you know for sure that there's no AFib? Because you did a long-term loop recorder. Thank you. So everybody with a stroke, control that diabetes. So diabetes control. Right, the diagnosis of diabetes is a hemoglobin A1C greater than 6%, but the target when you're treating diabetes is under 70%. Control hypertension, a completely difficult subject, and you're not going to have to worry about competing guidelines. Very difficult. Competing guidelines means that this organization says that blood pressure 120/80 is hypertension or pre-hypertension. Another group says 130, another group says 140. You're not going to get toyed with on that. No one's going to fail for competing guidelines. And risk factors. And no one ever says to start smoking, right? So whenever it says smoking, it's easy. You just say no. A, smoke a little less. B, smoke a little more. No, stop smoking. Stopping smoking is also the answer to the question, correcting which of these risk factors results in the greatest immediate improvement in mortality? Stopping smoking. Faster to see an effect than high blood pressure, and definitely faster than lipid control. See you in the next section.